I'm joined today in conversation with Cerys, Michael and Sue. We're going to be talking about SSI reduction and real-world data. The basis of our conversation is going to cover the domains of quality. So we're going to highlight a little bit around patient safety, patient experience and importantly clinical effectiveness. I'm going to introduce the colleagues that are around the table today as we go through our questions. There will be an opportunity for you to raise your questions and time throughout the presentation to share those questions with the colleagues here with me today. Please do post your questions, comments or observations and we look forward to being able to answer those and get back to you throughout the presentation. So first of all, I'm going to hand over to Cerys, who, if you could introduce yourself.
Hi everyone, I'm Cerys Stowe and I'm the lead nurse, tissue viability nurse for Hampshire Hospitals.
Cerys, would you like to tell us a little bit about how your experiences of how this affects patients and their outcomes?
Yeah, so it's a time in someone's life that they want to be enjoying spending time with their new baby, and it's the last thing that you want to have to deal with is to think about a wound infection and what comes with that. So it's going to affect obviously our patients physiologically and what comes with having a more severe infection, and then it goes on to things like the psychological impact it can have for someone and affect their sort of mood and their mental health basically at a time where you are quite vulnerable. You've got a new baby and it's just not something that you anticipate.
Yes, yeah.
I think when you're having your child.
It's supposed to be a joyful time,
yeah,
isn't it?
Yeah, and it's not something that someone should have to worry about.
Yeah.
So if there is something that's quite simple, an intervention that we can sort of offer that's quite straightforward, I think we should do what we can to help our patients have the best experience. At this time in their life, that they should be bonding with baby and not having a million other things to worry about and face being readmitted, being away from partner, family at home, feeling isolated perhaps, being readmitted. You don't expect that. That's something that's completely something unanticipated for you. You've not thought about that. I know for me personally, when I was a new mum, if you had a surgical site infection, would you be worried about taking antibiotics if it required that? Especially breastfeeding, that's another thing that's going to raise a bit of concern, isn't it? Even though it might be that drug is safe, you're still going to be a bit aware that that's something that you wouldn't have had to have taken if something as simple as a different dressing could have been used and prevented that infection. And also it comes down to the things like if it was a planned C-section, you would anticipate you're going to have a scar, but having then had a surgical site infection there, actually you might not be prepared for how that scar might be bigger or worse than you'd thought it would be. And that can affect your body image and the way that, all of these things. It's not just the physiological aspect of having a wound infection, it's the toll it takes on someone's mental health and their well-being.
I remember really clearly one of the new mums, and it was first baby, and she came back to us a number of times because of an infection that developed within her caesarean section wound, and her comments were, I always wanted 2 or 3 children, but I'm a little bit anxious now about what's going to happen, and is it going to cause problems next time? Is it, so there was the added anxiety that she had around not just maybe having another caesarean in the future, but what if it went, if it didn't go as she had expected it to. And I think the point you raise in terms of, it's a really important part of life, isn't it? It's a really big step, and there's a huge amount of physical and emotional social changes going on, especially with first babies and subsequent, that it's had a huge impact. And then the patient impact then knocks on to how we deliver our services and the operational effectiveness. isn't it?
Yeah.
So yeah, I think it's really good to start with the patient's perspective, because that's who we all are, isn't it? So
Yeah.
so we're going to move along a little bit now and talk about some of the evidence base behind SSI and the ability to actually reduce that within maternity services. For the sake of our guests that are joining us online, would you introduce yourself, please?
Yes, of course. So my name is Sue Jackson, and I'm the Acute National Strategic Healthcare Partner for Essity. So one of my main focuses is working with the team that work towards developing evidence about how best to reduce surgical site infection. And I think that it's really sort of reassuring to know that the intervention that we're here sort of discussing today, Leukomed-Sorbate, does already have NICE guidance behind it, and that was published back in February 2021. Okay. And it's always good to know that's in your back pocket, you know something works, but NICE is supporting it too. Mm-hmm. But I think probably more importantly, something that I find really resonates is we happened across some other work that was led by Katie Morris and the team in Birmingham. And this was a completely independent, large, systematic review and meta-analysis. And what Katie and her team found was that this particular technology is the only technology that is actually proven to reduce surgical site infection. So not only is there NICE guidance to support your clinical decision making, but there's also a very large independent meta-analysis supporting it too. But for me, and I know for lots of people, lots of clinicians that I talk with on a daily basis, what seems more and more important is understanding that strong evidence base does translate into your day-to-day hospital setting.
Absolutely, yeah.
And what I'd really like to do is hear from Michael, because I know, Michael, you've got some very recent experience of how it's worked for you in your hospital. So maybe you could share a little bit about that journey of implementation for you.
Yeah, of course. So I'm Michael Magro. I'm a consultant obstetrician and gynaecologist at Barking, Havering and Redbridge University Hospitals, and I'm the labour ward lead there. And I mean, our project really came about from two parts. We were struggling with sort of capacity within the hospital, and as I'm sure lots of trusts are. Yeah. We had women waiting on the antenatal ward for a very long time who couldn't get to labour ward because labour ward was full, and those women on labour ward couldn't be discharged off labour ward to get home realistically because the postnatal ward was full. So that's been tackled in a lot of ways, but one of the projects that we came up with was actually how do we look at the women on the postnatal ward and who potentially could go home sooner, or how do we stop women being readmitted? And at the same time as thinking about these type of projects, that's when Essity sort of approached me, and as the labour ward lead, I often get lots of companies coming to me saying, trial my product. And I have to admit, I didn't know about the NICE guidelines until Essity brought them to me. Yeah. But actually reading through them and with the team explaining everything, they seemed very simple. They had good RCT data, which is generally what you want. Yeah. And in some respects, it seems like a no-brainer. The guidelines say that if you switch to Leukomed-Sorbate dressings, you're likely to reduce SSI rates, reduce readmissions, and also save money. And it seemed a bit too good to be true, which is why we, as a team, sort of said that this sounds very good, but we want to audit our own data as well. Yes, we've got that great RCT data, but actually the dressings are more expensive than what we were previously using, so roughly £10 per dressing, versus we were using Mepor beforehand, which was about roughly £1 per dressing. Yeah. So we said, well, look, if we're going to be spending more money on these dressings, we want to make sure that it is doing what it says on the tin. So that's where we started from. We had previously done an audit in our trust looking at our SSI rates, but it wasn't as robust as the one that we've done more recently. So we only looked at women who had elective caesareans. We didn't really look at women in the community because, as Cerys was, as clinicians, we just didn't have the time or the resources to look at those problems. And most of the infections will happen in the community, so we were probably missing quite a lot.
And that's because the ladies were being discharged, weren't they, before
So
the SSI was presenting itself?
So the data that we looked at 12 months, January all the way through to the end of the year, 21 and 22 is when we implemented the new dressings. And we found that before we implemented Leukomed-Sorbact, a few women did develop an infection before they actually went home, even quite soon after. But the majority, 90% or so, were diagnosed in the community.
Yeah.
So unless those women got readmitted to hospital, us as obstetricians, we actually didn't see the problem.
Yeah.
So that's sort of where it all started. In terms of the data itself, we made sure that we compared like for like. So we wanted to make sure that we weren't comparing the new data from after implementing Leukomed-Sorbact to our old audit data, which wasn't going to be comparative.
Yeah.
So actually we were very lucky. We had an auditor from Essity provided to us. We made sure they had a robust honorary contract with the trust, so actually they're working for us, not for Essity, to make sure it's independent. And they were able to collect the data. I mean, that's their job. They're an auditor. They can collect this robust data that we were not able to collect. So we looked at 12 months pre-implementation, collected lots of information, demographics, SSI rates, and then we also implemented the wound dressing, collected all of that data going forwards. And the data I've got to share is, at the moment, 6 months. We've got January to June 2022. We are still collecting that data until December this year, but that hasn't been through the internal governance process and hasn't been shared with our internal teams yet, so that can't be shared externally. But what we've got is really, really good 6 months worth of data.
Yeah. And in terms of that 6 months of data, because, you know, those of us that work in the NHS know that there is no summer season anymore, there are no winter pressures, and so I'm guessing that 6 months was very representative of time on the labour ward and the number of births that you were having through your services.
Yep, so we're the third biggest single site maternity department in the country, which I think also helps because we do have we had big amounts of data.
Yes.
So that sort of natural variation month to month where you might not see any wound infection or at least readmissions that month sort of is slightly balanced out because we've got so many women. So we had roughly 1,000 women within a 6 month period had a caesarean section. Our caesarean section rate fluctuates probably by about 35%. It's probably similar to lots of trusts, but essentially we've got a lot of data to be able to balance it on.
And we were talking previously about the demographics of the population that you serve as well, which also, you know, we know can contribute to surgical dehiscence, so malnutrition, those kinds of aspects that you see in your patient population, don't they? So it, in many ways, quite a challenge. High birth numbers, busy departments.
Yeah. We had low socioeconomic groups in general. That's a lot of what our population is, sort of North East London, Essex is. But I think what we did very well is we looked at all of those demographics and we found that the women in the year preceding ultimately had the same demographics as the women going forward. So it was very much similar.
So it's very applicable. Yeah. Tell us a little bit about the cost pressure of implementing, because again, you know, we're often bombarded with lots of information and lots of things that can help us from to meet the needs of the quality domains. But when it comes with a cost pressure and our budgets are set on an annual basis, it can be a real challenge to overcome that, can't it? So could you share with us your experiences of that? Yeah,
so the NICE guidelines are very clear that for maternity for caesarean sections, that using Leukomed-Sorbact will be cost saving. And we're at a position, we hadn't implemented any other dressings, we hadn't gone to using Pico, which is something else that NICE recommends for us, a higher BMI. So we're at a stage where we sort of had free rein to move on to one, and I was very keen just to move on to one project at a time. Let's just do one thing. So we use Leukomed-Sorbact for everybody.
Yeah.
But as I mentioned, it's about £10 per dressing, it's £1 before. So although we were expecting to, if it worked, to save money, then it was an initial outlay which we as a trust hadn't, or as a department hadn't budgeted for. So we had to go through, any new purchase in our trust has to go something called the Procurement Advisory Group, or PAG. So with the help of Essity, we had a business case prepared, and we took it to that group, and they don't just look at money, because obviously sometimes we will spend more money and not save money, but it will improve patient outcomes.
Yes. Yeah.
But actually, we were able to say that there is NICE guidelines, it's got RCT data, we're going to improve patient outcomes, and we're going to save money. But one of the things that I really think helped sway their mind was we had already agreed with the audit department that this would be a prospective audit, and we were going to collect data for 12 months.
Yeah.
And at the 6-month mark, we would report back. And if it hadn't done what it said on the tin, and it hadn't reduced infection rates, we would go back to what we were doing before.
Yeah.
And I think they liked that idea, that we're not just going to buy
this
this
product.
product.
It's a bit of a safety net from a financial point of view.
We're not just going to buy this product and go with it, whatever it did.
Yeah.
But in terms of the data, I mean, we've had excellent results.
Yeah. Yeah, and I think, you know, as we move towards integrated care systems, it's also about recognising that the costs aren't necessarily just within one part of the NHS or social system, isn't it? And, you know, how important it is, and from a patient point of view, you know, that you can get back into your life quicker. Okay, that's fantastic. And just very briefly, Michael, what are your plans within your trust to use the dressing more widely? Because we're talking about maternity and the reduction in SSIs, but the principle of surgical site infection covers every kind of surgical intervention.
So we obviously started with maternity because that's where the NICE guidelines sit. But we've managed, over sort of 6-month period, we reduced our SSI rate by 45%. We reduced the number of women being readmitted due to SSIs by 36%. And actually for us, one of the really big things is we reduced the number of days women were staying in hospital by 61%. So it's the amount of time women spent from being readmitted.
Yeah.
And as well as that, because we reduced infections, because we reduced the number of readmissions and the length of time they stayed, we reduced antibiotic use by 36%.
Okay.
So I think we have real-world data. This wasn't set up as a study. We didn't need that, but we've shown that by switching the dressing, we didn't do anything else. We didn't change antibiotic use. We didn't tell surgeons how to close the wound. All we did was switch over from Mepor to Lucamed Sorbact. So although there isn't that NICE guidelines, it makes sense that for similar types of open wounds, it should do the same.
Yeah.
So we've already agreed with our audit department to set up a project in the new year looking at open gynaecology cases. Most of those wounds will be a low transverse incisions, your hysterectomies, your myomectomies, your cystectomies. But we're going to essentially do the same thing, switch over and collect robust pre and post implementation data.
Yeah.
I mean, our tissue viability team at the hospital are keen to potentially speak to our vascular team because that's where the other NICE guidance is. And the rest of my microbiology colleagues, I mean, they can't put a price on reducing SSI rates, whatever we try and do. And I think the surgical team are also starting to think, well, this is something that they might want to look into.
Yeah.
How you collect that data is probably going to be a bit harder because in maternity you have the benefit of the midwives seeing the women regularly in the community.
Yeah.
Maternity keeps vast amounts of data and we're now getting used to actually using that for good. Post hysterectomy, for example, you don't have that. Women go home. The only time we'll see them is if they get readmitted. So we will probably be looking at our readmission rates rather than looking at the community SSI rates. I think that's just going to be really hard to find. So
lots of opportunity, really.
Yeah,
and
huge.
I think, you know, what you described resonates with me from if you think about the quality improvement cycle and how you've approached this very much from a quality improvement. And we mentioned those domains in terms of experience, safety and effectiveness. I think for the benefit of the audience, we'll definitely be sharing the data afterwards because the figures that you just gave were, you know, significant and, you know, it would be remiss of us not to think about actually how else can we apply that in this setting.
We didn't start off with a particularly high SSI rate either. So when we're talking about these percentage reductions, we can share the actual figures.
Yeah.
I've been impressed by how easy it's been to do those savings when our infection rate wasn't particularly high in the first place.
Yeah. But for each and every individual patient, that's...
Yeah. And I think as Cerys talks
impact,
about, yes, we can talk about the money, we can talk about readmission rates, but actually the fact that we've just done something so simple and those women have had a much, much better birth experience is invaluable.
Yeah. That leads us really nicely on, Cerys, to you. So tell us a little bit about what did you consider when you were looking to improve the outcomes in caesarean section?
So basically, we wanted a simple and effective solution to some of these issues that we were having. Similar to Michael, we weren't sitting, highly with our surgical site infection rate, but I noticed a slight upward trend, and wanted to get in there and have a solution to the problem that we were facing. And we're an inpatient-only TVN service, so as you said again, when patients that have had their C-section, they're discharged home, and the midwives are going in typically day 5, that was when we were getting some telephone calls for some advice, or where do these patients go? Who do they fall to? Do they need to go to their practice nurse, who aren't perhaps as upskilled in this kind of wound and surgical site infection sort of issue that we were facing? So we needed something, nice and effective. The NICE guidelines were there to support sort of our decision making, and you've got the evidence there in the NICE guidelines to suggest it's reducing your readmission rate. It's saving you over £100 per C-section patient. We were already using a film island dressing post-op. It was typically on for about 24 hours. So it's not a huge change in practice. We're putting a dressing on. It's just more of an interactive dressing. It's got some bacteria binding properties to it, which is what we need. We need to get that bacteria locked away and addressed. We're protecting the wound when it's at its most vulnerable. So it was an easy, win-win for us, really. Something that we can put in there and just get buy-in. It was really important to explain to our colleagues in the maternity department and our community midwives what we wanted to achieve. We don't want to have an issue with surgical site infections. We need to address it now and have a clear pathway. Utilising this NICE guidance.
So it's very much thinking about it from a preventative point of view,
preventing the
rather
problem.
than reacting.
And all of the things I would expect to see savings, obviously with your readmittance, but midwifery time in the community. There's so many.
Absolutely.
You could go on and on with the benefits from having implemented something so simple as a change of dressing.
I think a point that Helen made earlier, and that was about capturing those costings as we move into an integrated care system and those silos coming down. I think what was really helpful, and Michael, you and I work quite closely together on this, but it's how you capture that PLIX data. And I know your costing submissions person in your particular trust is very efficient at capturing that PLIX level data. And so that was accepted by NHSE as cost saving. Although, as we've mentioned, this is a more expensive dressing, the overall cost savings and the operational gain to the trust on top of those clear patient outcome benefits really make it a very difficult case to argue against.
And I think we've talked about the patient, and rightly so, but also our experience of staff. Your heart kind of sinks a little bit, doesn't it, when you've seen somebody go through whatever intervention that we've provided, and then they come back with a complication, and you can see the impact that that's had on their lives. And when you know that there's a young baby there and dealing with all of that situation as well, many of us go home and slightly concerned about what's happening. So in terms of us having a good experience of work, that's important as well, isn't it? Cerys, Michael, can you tell us a little bit about patient criteria and dressing selection?
Me? Yeah. So I had looked at some studies done up in Wigan, and then Wye Valley. Basically, they'd had a set criteria of up until this certain BMI, we use Leucomed, and they've actually increased it up to 45-50, the BMI, and seen no increase in surgical site infections. So it's showing it's still doing the job for that sort of cohort of patient. So that was one of the things sort of I looked at. And then liaised with our obs and gynae consultant, and he was keen. And also, I know that you, Michael, said you weren't using PICO, but we didn't have a set pathway for PICO. It was kind of like the clinician's decision at the time. Is it a higher risk person? Shall I use PICO? And then they were kind of ad hoc used as and when. But I think it's quite fair to say we're probably seeing a higher proportion of patients with a higher BMI. It's not cost effective to go sticking Pico on. It has benefits to it, but we were quite aware that we can't just go and put that on everyone. So that was the reason for our sort of going with the BMI of 50.
I think it's useful, isn't it, to have a range of things that we can use in our arsenal to manage surgical site infection and surgical site... the word's gone out of my head. Dehiscence, that's the word. And I guess as your data evolves and over this second 12 months and considering the patient group that you serve, you'll then be able to sort of refine that patient selection criteria as you've just described. So that's really great. Sue, could you perhaps tell us a little bit, because one of the things that we wanted to talk about today was a bit of a call to action, so to share the real life experience, how to translate evidence and NICE guidance into clinical practice, how does it then help us meet the domains of quality. So from a call to action point of view, could you tell us a little bit about what's available and how Essity can support us in doing this?
Yeah, absolutely, of course. I think firstly, just to speak to that last point, which was about how we stratify and should we stratify when choosing addressing post-cesarean section. So the team at Essity, we offer sort of a three-tiered approach really. Our account manager team can support with education, and we have a clinical nurse team that have built an excellent toolkit called PATH that really helps support upskilling and helping get that sort of accredited CPD, accredited learning in place so that people are looking out for the right things. But what we also do is we have a strategic healthcare partner team that will help support you build pathways. For example, Michael's already mentioned the business cases. They can be very much a part of that as well. So they can support you with a business case and they can support you hand in hand to develop a pathway so that you get that consistency and that continuity between acute and community, because we know that historically that's been quite challenging. Sometimes communication's brilliant and other times it's maybe not so good. So that's something else we can do. That stratification and that pathway would obviously be very dependent on what that individual trust wanted. And I know, Michael, you decided to put leukomed across the whole of your patient group. And there's some very strong evidence behind particularly those higher BMI ladies and the reductions that you've seen in those, which again, the poster will be shared, I'm sure. Helen, we can make sure that happens so that everyone can see this on the call. So we can help you with the business case, we can help build the pathways on a practical level, help with the training, but then on a practical level from a patient perspective, we can produce things like patient information leaflets, little wristbands. It sounds like such a simple thing, but we found initially the first sort of vanguard trusts that were going out and doing this were finding that when the ladies that were then out in community, there wasn't that recognition of the dressing being there in place.
Being able to stay in place.
Yes, or being ripped off, something else put on. But we can produce wristbands just to help that, just to make sure that communication's there.
Okay.
So I would say it's bespoke. At the end of this, you'll see, and I think it might be in the chat, there's a link to our concierge team. If anyone is interested in finding out more, use that link and we'll get someone to come and visit you and help build a support package around you. And just the final point that I think is really important, listening to what Cerys and Michael have talked about today, it's about that surveillance, identifying, will this implementation make a difference for your trust, for your patients? And Michael already alluded to the fact that the audit support team were there in place. Now, that's a limited resource within the business, but because it's resonated so strongly wherever it's been used, what we decided to do is build a toolkit using that team's expertise. So there's essentially, it's like an Excel data sheet that gives you all the data points, that tells you exactly what you need to be pulling, exactly which systems to pull it from. And then there's a pre-populated template that you can put that data in and it automatically springs up a PowerPoint for you.
So that's fantastic, isn't it? Because that's one of the barriers that we often come across is that, you know, how to actually design a tool that can capture that data.
Yeah.
We've got a number of questions coming in from people that are with us online. One of the questions is, it sounds too good to be true. Can you tell us more about the dressing and how does it work?
Okay.
Cerys.
Well,
I think you've mentioned a little bit, Cerys.
Yeah.
Do you want to tell us a little bit more?
So it's quite similar to, you know, a film island dressing, I suppose, but the fact this is going to stay in place for 5 days, or some trusts have chosen a different set amount of time it stays in place for, but it's quite gentle as well to the sort of like the peri-wound, the surrounding skin, and then it's got its bacteria binding properties, so it's locking that bacteria in, keeping it away from the wound. It's as simple as that. It's quite a nice, easy dressing to...
Because caesarean sections, from my experience, can be quite leaky wounds.
Yeah.
So
it has...
maintaining the right balance at the wound bed.
Yeah, and it can manage up to a certain amount of exudate, but I wouldn't expect a huge amount if there was, you know, at closure kind of thing. So,
okay,
yeah.
Great.
I think, Michael, you found you had some comments and questions from your community teams, didn't you, when you first started using it, because of that level of...
And I think, it's
Yeah.
a question I've had actually on all the sort of calls and everyone I speak to. And I have to admit, I was in exactly that same position. So when Essity came to me and they said, here's a dressing, all you've got to do is switch over and you'll reduce your infection rate and your SSI rate and save money, I was exactly like that person asking the question. I was extremely sceptical. And that's exactly why I spoke with the Essity team. I said, I'm basically not implementing this unless we audit our data and we review that over that 4, 6, 12 month period. Because I'm not willing to pay that additional one, even though it's a huge amount, but if it doesn't do what it says on the tin. I think in terms of the dressing itself, obviously our women sort of were actually, our midwife said to us, lots of the time we were taking the dressing off at 24, 48 hours, and the women were even asking themselves, well, why are you doing that? You're exposing my wound. And that's just what we did. I mean, say you should take MEPAUSE off after 24 hours. So that's just what we got into the habit of doing. And the fact that you have this dressing that women can go home, they can shower with it on, it basically just stays on for 5 days in our case.
So one of the questions that we've had is about education, so we've kind of touched on that. Another question that's come through, which many of us will really be keen to hear your answers on, is what barriers did you come up against when you were trying to implement the change?
So I guess the first one was around procurement and the fact that it was more expensive. So, but with the good business case and the evidence that was already out there, and as I mentioned, sort of the fact that we were going to audit it, they were very happy with that. In terms of the clinical teams, we managed to implement a 2-week training program that's from Essity. That's all that we needed. So, but we did it at different times in the day. We captured staff before they finished their night shift. We did lunchtime video conferences. We did face-to-face in the evening. So we did basically 3 sessions per day for 2 weeks, a mixture of face-to-face and online. And then the ST team also went out into the community and spoke to the midwives. In terms of switching over, really easy, because actually our scrub nurses are the people who put the dressings on, and it's extremely similar and very easy to put on, like MEPAUSE. There's nothing fancy about it. So they were very quick to take it on board. Probably the 2 other challenges I found were around the community midwives initially. When the dressing gets a little bit soaked, or even if there's just a tiny bit of blood staining on the dressing, as would be normal, they were worried about should they then leave it on for another 4 days. So we were having, when community midwives were actually sending me photos of the wound and saying, shall I keep this on, shall I not? But within about a week, we managed to sort of have 3 or 4 photos of wounds and say, well, actually, no, if it looks like this, keep it on. If it looks like, and generally, unless it's completely soaked and actually the sort of sticky plaster is coming off because it's that wet, the whole purpose is to keep it on, because that's what prevents the infection.
Thank you. Karen, I hope we've answered your question, because there was a question about the education and the how to influence colleagues. We have got one last question. And I'm going to put all 3 of you on the spot with this one. The question is, so here's some thinking time. What advice would you give to a trust trying to replicate your work? and I'd like 1 or 2 comments or pieces of advice from each of you.
Okay.
So, Cerys, would you like to start first? Not so much thinking time for you.
Advice-wise, I think it's really important for your colleagues and everyone that's going to be using this product to understand it and have a base knowledge of how it works.
Yeah.
Application, I know it's pretty much the same as the whatever dressing you're using at the moment. Yeah. But I would say really, it's how you apply it, how you take it off. Is it as simple to take off? And what it does. Why have we gone to this dressing? Why has it been chosen?
Yeah. Okay, great. Thank you. Michael?
I mean, I would say just do it.
Just do it.
I mean, I don't think you've got anything to lose by trialling it. And if you collect your data and it doesn't make a difference, you can swap.
Yeah.
It's not an intervention that's going to have potential side effects.
Yeah.
We're not trialling a new drug. We're not doing anything fancy
safe, isn't it?
that we're not going to cause complications with.
Yeah.
So I don't really see, now we've got RCT data, we've got real world data, we've got nice guidelines, why you wouldn't just try it and see.
Yeah. And if we're thinking about the whole pathway that the person's gone along, and the impact personally that we talked about.
I think the final thing I'd say is that I would do one thing at a time, and that's very much what we did. I've had feedback from other trusts who try one thing 1 month, and then their results are slightly different than what they're expecting the following month, and they switch back.
Yes.
So even with our huge volumes of data, you will find there'll be a month where you have 0 readmissions, and the following month you might have 3. Yeah. But if you're only looking at 1 or 2 months, you don't have that ability to actually see what's going on.
Yeah. And final point from yourself, Sue.
Okay. I think from my experience, I would say there are so many stakeholders involved, and when you're working on your own as a clinician, if you can get those stakeholders around you, understanding why you want to do it and being supportive, it makes it go so much more easily. And I think the one big learn that's come from recent changes is now in the acute sector, it's certainly mandated that you capture PLIX level data. In the community from springtime next year, it will be too. I would say find out who your costing submissions person is and work with them, because if the knockback that you're getting is over cost, they'll be the ones that will be able to demonstrate those cost savings for the trust as well as the patient benefits, which is so clearly obvious for all.
And that's what our trust boards are interested in, isn't it? Is that, that what we're doing is safe. It gives people a good experience and it's an effective use of our resources. So thank you so much. We've reached the end of our time. Thank you for those that have joined us. I'd like to say a massive thank you to Cerys, to Michael and to Sue for joining me today, for sharing such amazing work with us. Thank you to Essity for sponsoring today's event in collaboration with Wound Care People. We've mentioned a couple of times that this is a call to action for us to think about surgical site infections within maternity services. I'd just like to raise your attention to the email, which is concierge.service@essity.com, or you can call the concierge service on 01482 670 177. I'll just repeat that because I tripped up on it. So you can call on 01482 670 177. Thank you so much for joining us, and we look forward to seeing you again. Thank you. Thank you.
Thank you.